Okay. Hey, everybody. Thank you for joining us today. My name is Matt Wellington, and I'm going to be your moderator for today. I'm the Public Health Campaigns Director with US PIRG, which is a nonprofit, nonpartisan consumer advocacy organization. And we have a great panel here for you today. I'm going to introduce those folks in just a sec. I want to give a quick shout out to Doctors for America and Get Us PPE for co-hosting this event today. We're very grateful for their partnership and all the work that they're doing with health professionals across the country on these issues. So we're very lucky to have our panelists here, folks who are on the front lines, taking time out of their very busy schedules to join us and share their perspectives on COVID-19 response. First, we've got Congressman Andy Kim with us today. He is in his first term representing New Jersey's 3rd Congressional District, which spans from the Delaware River to the Atlantic Ocean. Congressman Kim is a native of South Jersey and a Rhodes Scholar. He has spent most of his life as a public servant and a national security expert, and it is because of that expertise that Speaker Nancy Pelosi appointed Congressman Kim to the House Select Committee on the Coronavirus Crisis. And he is the only freshman representative on that select committee. Congressman Kim lives in Burlington County, New Jersey with his wife and 2 baby boys. So thank you so much for joining us, Congressman. We also have Dr. Jeremy Faust joining us. He is an attending physician in the Brigham and Women's Hospital Department of Emergency Medicine in the Health Policy Division and an instructor at Harvard Medical School. He's also a columnist for Slate, and as he told me, focuses on the intersection between policy, medicine, and communications. We're also joined here by Dr. Julie Parsonnet. Dr. Parsonnet is a member of the National Academy of Medicine, a professor of infectious diseases and epidemiology at Standford University, and a member of the National Board of Directors for Doctors for America. And lastly, we've got Dr. Joe Kanter coming to you from Louisiana. He is the Assistant State Health Officer for the Louisiana Department of Health and the lead public health official for the Greater New Orleans region. He's also a member of the Board of Directors for Doctors for America. So thank you to all of our panelists for joining us here today. So I want to very quickly set the stage for what we're going to discuss. COVID-19 is currently killing more than 1,000 Americans a day. We've surpassed 1 million cases across the United States. And 2 months into this pandemic, health professionals still say that they don't have adequate supplies of personal protective equipment and other medical equipment that they need to not only protect themselves, but properly care for patients. We also are not nearly to the testing capacity that health experts agree we need to get to in order to properly track and trace future outbreaks. And all at the same time, recent documents came out from the government that show we could very well see a spike in COVID-19 cases in the coming weeks as some states move to reopen. So our panelists will talk about these issues and how they've experienced them from very different parts of the country. So I think we'll have a great discussion with different perspectives. And most importantly, pose potential solutions for how we're gonna move forward in these issues. So they'll give short opening statements and then we'll ask them some questions and have discussion. Congressman Kim unfortunately has to leave us at 2 p.m. So we'll make sure we keep these opening statements short. And then we'll have discussion while he's still with us and direct the first set of questions to him. So with that, I'll pass it over to our first panelist to start, Congressman Andy Kim.
Great, thank you so much for having me here, and it's an honor to be on this with a number of other just incredible experts who are much more knowledgeable than me about this. But let me just kind of dive right in. So as mentioned, I represent the New Jersey 3rd Congressional District. I'm a former national security official and on the select committee on the coronavirus crisis. We're very eager to move forward with the work of that committee, just given what is at stake right now. This committee is going to be focused on handling the oversight over the relief packages, the multi-trillion-dollar, the largest relief package in the history of our country, as well as oversight on the health crisis and the response, including some forward-looking thinking about how to responsibly reopen, how to prepare for a second wave, and how to supercharge the development of the vaccine while doing it in a responsible and safe way. And thinking not just the development of the vaccine, but how do you scale to be able to produce that and be able to actually push that out to the public in a scalable way. What we know with testing and personal protective equipment, what do we know about this? Well, we know, first of all, that we're not doing enough, that we don't have enough. There's been a lot of chaos in the system. In many ways, we've become our own worst enemy, especially when it comes to counties fighting other counties, states fighting other states. There's no coordination to this process. And that's something that I think a lot of us have been calling for and trying to get federal government intervention to be able to help this. We tried to pass that in the last bill where we included $25 billion for a national testing program. And these steps to try to make sure that we can move forward on testing and the personal protective equipment, especially for our frontline healthcare workers. As I've talked to hospital workers in my own district who tell me they work on COVID ICU unit floors, and they don't have enough ability to get tested themselves and know whether or not they're safe and healthy, not just for the benefit of our healthcare workers, but it's certainly for the benefit of patients and others that they're coming into contact with. Right now, we want a federal government that can be able to handle the supply side of things. That includes assessing needs. It's about securing supply chains. It's about generating those supplies and utilizing mechanisms like the Defense Production Act and other actions to be able to make sure we have enough, to be able to coordinate the distribution of this so we're not fighting each other, a bit like an air traffic controller, but also that includes the prioritization. And this is going to become all the more important as we start to open back up. That businesses, schools, every aspect of our society is going to be trying to get personal protective equipment and testing. Well, we need to make sure that that prioritization is there so healthcare workers are being able to get access to this, that the broader public is not consuming and taking that away from the healthcare workers that so badly need this. So some of those are key steps about this. We can talk about some of these other issues going forward, like antibodies tests, which will help relieve and alleviate, hopefully, the PPE, as long as we can determine what is a level of immunity that we have still yet to identify if that's possible, as well as preparing for a second wave, building up the stockpiles to be able to get ready for that, which many experts say is inevitable. So those are just a few other things and aspects of this that we can talk about, but for the purposes of time, I'll conclude there and we'll move forward. Thank you so much.
Thank you, Congressman. Definitely looking forward to following up on some of those things you just mentioned. So now we'll pass it over to Dr. Faust for his comments.
Good afternoon. Thanks for having me. I'd like to take you back to early March when I worked an overnight shift in my ER. And I had 3 patients that night with what we call multifocal pneumonia. And this is pneumonia that has not just camped out in one part of the lung, it's in many locations. We call it multiple foci or locations. And these pneumonias were all over the lungs, as if like 5 or 6 grenades had just been thrown in there. And one of the patients was older, and I might see that every week or two, and that didn't surprise me. But I saw 2 patients who were under the age of 60 years old with no real risk for that. And I immediately understood that we had a major crisis on our hands with COVID-19. And I had the light bulb moment in which I realized that I wasn't permitted to test them because I didn't have tests. They didn't reach necessarily the criteria. And I also realized in that moment that we needed to have enough tests for every single American because that would save lives, because I was worried that these people would be spreading the virus not knowing it. At that point, there were 538 cases in the United States that we knew about, and we were testing 700 people per day. Today, we have over 1.3 million cases, I believe, and we're testing 300,000 people per day. And I just think that there are many things that we can look back upon and say, woulda, coulda, shoulda. But if we are honest with ourselves, we have to acknowledge that most of those insights emerge with the benefit of hindsight. I'll give you an example. In late February, the stock market was at historic highs. We had no idea the effect that this was going to have on us. But there is one thing that we could have and should have done in which hindsight was not required. And that was to develop a comprehensive national testing strategy that really befits the size of the potential problem that we could have faced and the one that we do. We knew the genetic code of SARS-CoV-2 in early January, which is a staggering achievement for science that we can do that. Our colleagues in China provided us with this information, and we could have scaled up capacity in January or February. And if we had done that one thing, countless lives would have been saved. And this is an unforced error. It's too late for the 70,000 Americans who have already died and their families, but it's not too late for some of the next 70,000 who may die and the next 70,000 after them and so forth. And so this remains a priority. And I know the White House believes in the government believes in the utility of testing. They test themselves all the time. And I'm really glad to see that they get it. But I imagine that every American wants to feel that safe as well, that universal testing is something that we all want. Testing not only saves lives because it helps people know where the virus is, especially in a disease that spreads in asymptomatic people, which this one amazingly does. But I also argue that it saves money. So to moving forward, every dollar we spend, I would predict has an enormous mortality and economic benefit. And that's what we need to be striving for. Thank you.
That's great. Thank you, Dr. Faust. So now we're going to pass it over to Dr. Parsonnet.
Hi, thank you for having me. I'm a professor of infectious diseases at Stanford, and I see patients and do research, and I also teach undergraduates and graduates about epidemics. I'm also a board member of Doctors for America, which is an organization of 18,000 physicians that focuses on devising solutions to healthcare problems, including COVID. Like with Dr. Faust, at Stanford, the month of March was a very stressful month. The first known hospital case in our county, which happened at an outstanding community hospital with terrific doctors, went undiagnosed for almost a week. The infectious disease doctor had to plead for testing since the patient didn't meet testing criteria. And ultimately they did test this patient, and dozens of healthcare workers had been exposed to the virus and then had to be quarantined, and some of them actually got sick. At Stanford, a wealthy and very connected institution, we had shortfalls in PPE, particularly in masks and gowns, and we couldn't get the necessary supplies for COVID testing. First, even after the tests appeared, we couldn't get the reagents, then we didn't have swabs, then we didn't have transport medium, then we couldn't get kits. And everybody across the county, the state, and the country were fighting to get these supplies. There was actually almost a strike by our hospitalists who were concerned that they weren't getting sufficiently protected. Now that we've reached mid-May, I'm very grateful to Stanford, and I'm very grateful to live in Santa Clara County and in the Bay Area. We've had strong leadership all around, from the hospital on up. Our county, which has been led by Sarah Cody as the health officer, directed the first shelter in place, and it's greatly lowered our case count. The county has also effectively managed supplies so that healthcare providers, from local dentists to nursing homes to major hospitals, can now get what they need. And we're down to just handfuls of cases every day in the county and very few deaths. And so right now, we have adequate supplies, and I think our healthcare workers feel well protected, although I know that's not true across the country. And this doesn't mean that there aren't still enormous problems. Every institution, every county is having to devise its own strategies. How do we get supplies? Whom do we test? How and how often do we test them? Can we get resources to do this? If we have an asymptomatic doctor who tests positive, when can they go back to work? How do we protect families when healthcare workers are infected? When do we open elective surgery? When do we open clinics? If the community opens, when universities, schools, and stores and businesses open, how will this affect our patient load? And will we need to keep surge capacity forever? What criteria will we use to make these decisions? How do we get anti-COVID medications? Remdesivir now has a completely opaque and inequitable way to get this medication. So requiring every institution to devise its own approach is enormously inefficient and very, very stressful. No one is sleeping. Everyone has been firing on all cylinders now for months. It's exhausting and it's not sustainable. So my take is that we need clear, consistent, and coordinated guidance from the state and from the federal government. And every state and every county and every hospital is on its own with under-resourced and understaffed hospitals and health departments is simply just not a good way to manage this epidemic.
Seeing vigorous head nods during your comments from Dr. Faust and Dr. Kanter. So I think you hit on some important points, Dr. Parsonnet. So with that, we'll pass it to our last panelist for his opening statement before we jump into questions. So Dr. Kanter.
Thanks, Matt. And Dr. Parsonnet, I agree with every word you just said, and Dr. Faust as well. It's good to be here. I serve as the lead public health official for the greater New Orleans area. I work for the Louisiana Department of Health. I'm also an ER physician like Dr. Faust and a board member of Doctors for America like Dr. Parsonnet as well. I'll tell you a little bit about what's going on here and kind of give you the perspective from a state health department side trying to procure the supplies that we're talking about. Currently we have just over 30,000 cases of COVID in Louisiana. of which 45% are in the New Orleans area. We've had about 2,150 deaths, of which about 41% are in the New Orleans area. We had a very fast start to our outbreak. We actually had a sharper increase in case counts during the first 2 weeks of the outbreak in Louisiana than anywhere else in the world, with the caveat that the data in other places I don't think was as good. But we went right to community spread. We increased cases very quickly. And I'll tell you, our initial projections, looking at what our R0 was tracking, put us at a place that would have been 2 weeks ago of us exceeding ICU and ventilator capacity by a magnitude of 2 to 3 across this region here, which was a very scary place for us to be in. Our struggles with PPE, and I'm going to loop ventilators in with that as well, early on, match what has been said already. There wasn't enough here. Hospitals typically, on a good day would have 2 weeks supply on hand, but that's pushing it. And the procurement methods coming in, as Dr. Parsonnet meant, were so opaque as to be almost meaningless, and you really had to reinvent the wheel. Our frontline workers, not doctors, nurses, and so forth, they were doing all the conservation strategies, if you want to call them that you saw across the country, reusing gowns, cleaning them down between patients, reusing N95s for many days on end. And to have to do that with devices that are really intended to be single-use, disposable, is not a good place to be. We had a number of healthcare exposures here and a number of nosocomial transmissions. Far from ideal place. From a health department standpoint, one of the most frustrating parts of this was, again, as Dr. Parsonnet mentioned, how disorganized the procurement framework was. We found ourselves competing against other states and other hospital systems and even the federal government on the private market for supplies and for ventilators. We found ourselves having to make multiple purchase orders just to try and hope that one of them lands. So for if we needed X number of ventilators, we would make purchase orders for 8 to 10 times that amount with multiple different vendors, because we knew having a purchase order signed on paper is meaningless until you actually have the ventilator or the PPE shipment come in. It's like that Seinfeld where he goes to rent a car and the reservation was meaningless. I thought I reserved it. So a lot of duplicity of work, a lot of time spent by my team members that I would have rather have them do more important things, and not a lot of predictability. I couldn't tell you what we would be receiving tomorrow from the national stockpile. I couldn't tell you what we would see shipped in from our private vendors. In the end, we were quite successful at flattening the curve in the New Orleans region through very aggressive social distancing measures, and it saved us the run that we were fearing. But had that not happened, we would have been in a really, really challenging place and not even able to really plan, because you really have no idea which of your purchase orders are going to hit tomorrow. Are the feds going to go and outbid you with another vendor? Are they going to deny shipment, send it to some other place for a reason that you have no idea? And it just caused our team members here to spend a lot of time and energy, standing up these really Byzantine procurement systems and spinning their wheels on it when there was other really important work to do. So, what I would like to see going forward, I don't think anyone expects that a national stockpile would have enough ventilators and PPE for something like this, for a once in 100-year event. That to me would be a little bit far-fetched, in all honesty. But I would like to see the federal partners step in and organize both the private and the public procurement methods. A little bit more assurance that crucial supplies like ventilators are going to go to where they're needed most. I don't think you can leave that just to the private market, because you have a lot of duplication of effort and no assurance that really life-saving supplies are going to go to where they're absolutely most needed at that point in time.
Yeah, I think on that note, Dr. Kanter, given our time here, I want to make sure we jump into the discussion. I think that's a good point to shift. So We're going to direct the first set of questions to Congressman Kim since he has to jump off a little bit early. And I want to ask the first question, and then folks who are on the Zoom line should type their questions to Congressman Kim or questions for the other panelists as we get to them into the Q&A section. So Congressman, I know you mentioned the Select Committee on the Coronavirus Response, and I know it's designed to be bipartisan. It doesn't seem like Republican leadership has appointed any members yet. So I wanted to ask, when do you anticipate the work to begin of the Select Committee, and what do you think should be the first order of business for the committee's agenda?
Yeah, happy to talk about that. So the Republican side did name their members yesterday. So it'll be led by Whip Scalise on their end. So having Clyburn on the Democrat side and Scalise on the Republican side shows that both sides are taking this very seriously. And while I'm sure I know that they've expressed concerns on their end, Scalise also laid out a couple issues that he thinks we can hopefully find ways to work together on, including issues of public health and issues like that we're talking about today. So I'm hoping that we can find some way to move forward. We have already started working forward on initial work on a number of issues across the board, including the implementation of relief packages and other elements of this. We are still developing up where we think we can be of most help. So certainly interested in taking any and all advice on what the Select Committee should be focusing our attention to, as there are any number of problems out there. What I think about often is kind of building off of the others, and being the only non-medical doctor on the panel, I want to just kind of focus in on where I think I can bring some insights. A lot of it is just trying to think through what role can the government play that no one else can, or that others can't do effectively or efficiently. So when Dr. Parsonnet is talking about just this fend for yourself situation that a lot of hospitals have found themselves in, those are some of the areas where we need to figure out what can the federal government, what can state governments do to try to improve that in terms of having greater transparency, in terms of what's out there, in terms of supplies, having stronger guidelines on usage, on what's available. Key things like data centralization. The fact that we're still not centralizing data from all corners of this country and requiring certain types of inputs for us to then be able to track. There are certain places where we need to make sure we're focused in on. And this is something that I'm going to continue to do through my work on the Select Committee. But like I said, both in an oversight way as well as going forward. So want to continue to stay in touch, because when we're looking at how to safely and responsibly reopen, we have playbooks on this with testing and contact tracing and other proven tools. But also in terms of preparing for the second wave, recognizing that we're in this for a long haul, and that the shortages and concerns about PPE at hospitals and with healthcare workers will continue dramatically. So we're going to continue to push on this, but those are some of the ways that we're going to try to be of effect with the Select Committee.
Right. And that does bring me to the next wave, right? So government reports are showing we could see a big spike in cases. And this question just came in from the audience that I think starts to get into, will we be ready for that? So the question comes from Shelby from CNN. So what is the current state of PPE for most hospitals and clinics across the country? And I think, Congressman Kim, if you can speak to what kind of data the government does have to analyze that, if you've seen that, and if we know at all. And then it seems like it's getting better in some places compared to a few weeks ago. So if that's the case, it would be good to flesh that out. So we'll start with Congressman Kim and then see if our other panelists can weigh in on that question.
Yeah, well, look, it varies greatly across this country. And from the hospitals that I've talked to, or the other medical facilities I've talked to, a lot of it has been still fend for themselves. While they've gotten some allotments from the national stockpile or other resources, that is still very much hospitals going through their own supply chains, going through their own vendors that they have relationships with, and sometimes having to take a chance on other vendors that are unproven. And so, this has been a real problem on that end. And look, we are Are we in a better situation now than we were in March? I think across the board, most would say yes. But the problem is that this is still a moving target here. It's a moving target on a moving vehicle. We don't actually know when this crisis will start to come down. We don't know if there's going to be a second peak, and if so, when and how bad. So, we really need to make sure that we are prioritized across the board. So when we are talking about reopening, we don't know how that's going to affect the situation. Here in New Jersey, I just looked, we have over 135,000 positive cases. We're going to probably hit 9,000 deaths today. If New Jersey were a country, we would be number 8 in the world for positive cases and deaths. So, when we think about my district with the Jersey Shore, people wanting to open back up for Memorial Day, what is that going to do? And so these types of variables make it hard to say where we're at when it comes to PPE. And what I do know is that where we're at, it's being, we're even if we're in a better position, we're using it almost immediately upon a receipt. And what we need to be able to do is get to a place where we have access so that we can rebuild our national stockpiles, so that states can obviously start to build up their stockpiles, and hospitals and other facilities will want to as well, just given the concerns that we had back in March about whose job it is to be able to stockpile. So we need to be running at an excess so we can rebuild these stockpiles, get ready for potential second waves, and get ready for other problems down the road. So that's where we're at right now.
Right. Yeah, and I saw one of our other panelists had a follow-up question for you. So Dr. Faust, do you want to weigh in and ask that question?
Yeah, Representative Kim, I'm wondering if the committee is thinking about asking or requiring hospitals to report to the CDC's national healthcare surveillance system that's been rolled out, to say 7,000 or 8,000 hospitals to be required to tell everybody what they need, what they have, and that way, instead of this sort of informal network, that it's actually just the way just the way that hospitals are required to report on their hospital acquired infections, they're actually also required to report on all the issues that you just brought up. Has that been thought about?
Yeah. Well, look. Thanks for the question, and the Brigham. So obviously, I have a lot of great thoughts about that. Glad you're holding down the fort there. What you raised is exactly what I've raised. I raised that several weeks ago, both in terms of the centralization of data regarding the virus and the spread of the virus. I thought you made some analogies that are very similar to mine, that I often liken testing to a radar system, our ability to see where the virus is moving. So I find that calling it an invisible enemy is not true. It's a way that we can see this through testing. And then in terms of the supply chains and in terms of the PPE, et cetera, I agree. There needs to be a centralized place where we can analyze that, assess the needs, look at the needs in conjunction to what we actually have on hand. And that is the only way that we're going to be able to make determinations of whether or not we need to take on actions like the Defense Production Act. And if so, that helps us identify how much do we actually need to be able to increase. So when I hear the White House say that they are moving forward on the Defense Production Act and other efforts, I'm asking them, how are you making your determinations of what we're asking for? If we don't have some type of understanding across our entire country of what the situation actually is. So I absolutely am trying to push for that. That is something that I hope that we can raise through the select committee and through the work that we're going to be pushing on in terms of how we, start to take some of these next steps. Or thanks for raising that, and I'll let you know how it goes.
Okay, thank you.
So I don't know if you have time for one more follow-up, Congressman.
Sure.
I have to jump off. We've heard a lot about the need for federal coordination, transparent coordination. What do you think is the basis and the rationale for the resistance to having the federal government take further control over these processes? And this is a question from a guest in the audience. What's your take on that?
I've asked that question direct to the White House, direct to FEMA, direct to every other aspect of the executive branch. I mean, look, for me, I come at this as a national security official. I've worked under both Republicans and Democrats as a diplomat and a counterterrorism expert. I was at the White House for 2 years as a point person on the counter-ISIS war. So I helped run a crisis response unit out of the situation room for 18 months. And I've seen how the coordination of these different aspects of a whole of government approach can manifest. Now, obviously, a pandemic is a very different type of national security crisis, but still, the mechanisms are very much the same, and a lot of the places we need to be pushing on are similar. So there are ways that we should be able to approach this, and I really urge that the executive branch, the White House, treat this as the national security crisis that it is, and in the same way that it would step up if there was any number of other types of national security crises. I work on the Armed Services Committee. When we're dealing with a lot of issues like missile defense and other issues, we don't ask every state to build their own missile defense radar systems. We don't ask every other state to develop their own national security infrastructures in different ways. There are roles, again, that the federal government can play that nobody else can, not even states. And some states are trying to get around or trying to manage the situation by coming up with consortiums and collectives among states to just try to increase their buying power and increase coordination, but they're still not going to be able to have the full effect that the federal government can have. So I will keep asking that question that I think will be a key part of the oversight side of things, is to really understand what their vision for the federal government's role is and why they don't think that they need to take a greater action. I've asked and requested FEMA to open more testing sites in New Jersey and elsewhere, and been soundly rejected every single time, and they told me bluntly that this was coming straight from the White House to not approve any more federal testing sites run by FEMA and HHS in the entire country. So, these are certainly coming straight from the top, and something that, we need to continue to continue to ask about and continue to challenge.
Right. Yeah, thank you for that. And I think last question for you, Congressman Kim, because I think you have to probably jump off here soon. This gets to a comment from Dr. Parsonnet earlier, and one of our audience members just asked, for over 20 years, the public health system has been underfunded. Even the ACT cut funding for prevention and public health funding and preparedness. So can you describe quickly a March plan for how Congress can fund public health moving forward?
Yeah, well, look, this is exactly the kind of conversation we need to be having. And I'll say two things here. One is we need to reimagine what we understand as infrastructure in our country. I think this crisis has really identified that infrastructure isn't just about roads, bridges, tunnels. Infrastructure is also about high-speed broadband, for instance, that is keeping our world connected, keeping our schools going, and keeping our kids educated in any number of other ways. But we also need to be thinking about healthcare and about the different parts of this that all of you are working on as critical infrastructure, as places where we need to think about not just the resources and the hardware, but bringing up more on the talent development and the workforce development, but also thinking about it as a system that's integrated. One aspect of infrastructure is that it needs to be connected in. Our roads, our bridges, our tunnels, our broadband access all needs to be connected in. Our healthcare system needs to be better at that, and we need to be thinking about that as a holistic system that is able to be able to respond with much more unity and coordination. Now, number two, what I'll say is that a lot of the discussion and a lot of the focal point for that conversation needs to have you as medical experts and others in the room to talk about. This is not for me, as someone who's not a medical expert, to dictate to you and to other hospitals or to design this. I'm really sick and tired of just decisions being made in Washington that don't have the people who it affects the most in the room, to have their voices there, to hear from them and understand what that's actually going to impact. So that is something that I'm very dedicated to doing with this select committee as we look forward, try to think about what lessons learned that we can implement immediately, those that are more mid to longer term, but making sure that we have the experts in the room, that we'll listen to them, and those are the voices that we're raising up. And that's a big reason why I wanted to join on with the panel today, is because I've just greatly respected the work that you all have done I want to continue to work alongside you, and I want you to know that the select committee, that we're going to roll up our sleeves and do our best to deliver for the country in this time of need. So on that, I will have to take on off now, but we'll stay in touch and continue this conversation. To the rest of the panelists, I look forward to staying in touch and drawing upon your expertise going forward. Thank you for everything that you're doing.
Thank you, Congressman, for joining us. Yeah. Okay, so now let's shift to talk a little bit more about testing. We have another question from the audience about testing that I think will open up to all of our panelists here. Any thoughts on the frequency of PCR testing for all healthcare workers as more testing becomes available? And that's from Donnell from California. So I'll open that up. I think Dr. Faust, you want to start first since you spoke primarily about testing, and then we'll see what other thoughts we have.
Yeah, it's a very important question, and I think that not to punt on it, but I would say it just depends on how many tests you have, because unfortunately, tests are a finite resource. That should not be the case in this country. They should be essentially like tap water. I mean, that's how we need. Look, you will know when you have enough tests in this country when you can get testing on demand the same way you get a flu shot. It's at the if you have enough, basically every pharmacy in the country. Like that tells you the needs of a community is the pharmacies. You don't drive halfway across town to go to a pharmacy. You go to the local pharmacy. That's how close every testing site and opportunity needs to be to every American. So we got to get to that. But if in a rationing society, a society that's rationing tests like we are, then we have to prioritize, as the question alludes to. And I would spend a lot of my tests on nursing homes, where an enormous proportion of our morbidity and mortality has come from. And I would spend a fair amount on healthcare workers. So I can't answer the question of how often, but I can say that that's the way to prioritize this, is that people who have the most number of contacts with the public. The other piece of this I might throw in is that we might need to rethink how we're testing. I'm beginning to talk about this with a colleague at Yale, Harlan Kremelt. He and I are talking about abandoning symptomatic testing and just focusing on asymptomatic people, because contact tracing will only work for the symptomatic cases. It won't work for the asymptomatic. So fine, let's contact trace for that group and focus on high risk asymptomatic carriers on the other side.
Right. So Dr. Parsonnet, I know you have a lot of experience with outbreak investigations. I know testing, I'm sure, comes into that. So what are your thoughts on the question?
So let me just start by saying, again, Stanford's experience, we just tested everybody at Stanford, every healthcare provider at Stanford, 15,000 people. 0.3% were carrying the virus, all of them asymptomatically. It's a lot of work and a lot of time and a lot of effort in the labs and a lot of expense to do that and to do it over and over again, especially when the rates are really low. The antibody rates were about 1.5%, but the carriage of the virus was about 0.3%, quite low. So we've been talking a lot about screening strategies, and one of the things that we've been and there's no answer to this question. So let me just say nobody really knows the right approach, how to do it, how often to do it. But I think people are trying to think about a sentinel chicken approach, if I could say that. So sentinel chickens are chickens that we leave out outside, and then we look to see if they've developed antibodies to West Nile virus, for example. And that's how we know that there's disease in the community, is by going to look at leading those chickens and seeing what's going on. And we're trying to see whether there are ways that we could really identify the people who are at highest risk, who we know are going to have the most intense exposures, whether in the population or in the hospital, and to test them pretty frequently. And not test everybody really frequently, but to try to test the people that we think are at highest risk and use them as markers for the community having disease and for us having to then expand to test more people.
Right. Okay, so Dr. Kanter, any perspectives from Louisiana? And then I want to go back to this idea of the next wave and are we ready?
Yeah, listen, if you are in an area with ongoing community spread, you cannot ever be testing enough. You're limited by your resources, and you're limited by how much value you want to put on the lives of those in your community. Look, in the White House now, President and his circle is being tested daily. And visitors that go in, every single visitor, even our governor when he went last week, gets tested before they enter the building. So that's the state of play now with what we know about asymptomatic infection and transmission. I don't see how you argue otherwise. If you have ongoing community spread in your community of a certain level, you can never be testing enough.
Right. So to go back to this question of the second wave, are we ready for a second? And we'll start with Dr. Kanter. Yeah, projections are showing in the coming weeks as states start to reopen, we'll see a spike in cases. You've talked to me about the stress and the anxiety that having to make these multiple purchase orders and dealing with the supply chain has caused even now. Where do you think you'll be when the next wave comes? Do you think that you've got lessons learned from the first round that you can put into practice pretty quickly if we do see that second spike? And what do you think about that?
I think so. You know, one of the good things that that the White House did do recently is they organized kind of a ventilator loan share program between large hospital systems around the country. A couple of our hospital systems here play into, and that's a smart thing to do, to kind of share resources broadly like that. I think that puts us in a better place. I mean, I feel much better postured, you know, if we have a second wave in the fall. But you know, that's at the expense of the lives lost and the slow start that we've had. You look at the data coming out of New York right now and the genomic analyses, you know, because there was limited testing, we were 2 to 3 weeks behind the 8 ball on this, and things spiraled very quickly. So those are lessons learned. I think we're going to be better off down the road, but it took a lot of loss to get there, I think.
Right. So Dr. Parsonnet, from California's perspective, you had mentioned to me when we spoke that the health department is figuring out ways to get PPE to other parts of the state, because you said in Standford, you're in a pretty good situation, but that is not the case for other parts of California. And we just got a question from the audience that says, Governor Newsom announced plans to buy millions of units of PPE from China. So does California, do you folks on the ground like yourself have a way to know if those have arrived and are being distributed? And that's from Ellen Schaffer, Dr. Ellen Schaffer from San Francisco, asking that question.
So I can tell you on the county level, they know where all the PPE is. The county has asked every healthcare provider, every institution, every dentist's office, every hospital to tell them what their supply of PPE is. And they know where there's excess and they know where there's not enough. And they also have a stockpile. So they are using that stockpile to distribute to people who don't have enough. I think they don't think their stockpile is big enough, and it certainly won't be big enough for a second wave, but they do have some stockpile right now. They are not actually considering moving PPE around. They're considering using that information to move patients around so that patients who are sick go to the places where the resources are the best. So that's the current county plan. I think the state has a little less information than that. I do know that the state has been using the California National Guard to move stockpiles of PPE to places around the state that require them. I know that they're very anxious to build up their stockpiles so that they're able to act flexibly and act quickly to distribute those around the state as needed. The problem with this epidemic, as anybody would know from looking at Gallup, New Mexico, is that disease can pop up anywhere, places that you really don't expect it, places that may be relatively, you know, off the beaten path a little bit. You can see it pop up anywhere. And so there has to be a way to be able to move the PPE around. I think the state is very aware of it. I'm not sure that they have worked out the kinks yet.
Right. Yeah, and I think this is in the same vein, but with testing, a question from the audience about the difference in the tests and difference in quality. So we'll direct this to Dr. Faust. So the question is from Dr. Sill from Johns Hopkins. He says scaled up testing is critical, both for PCR and serology tests, but they play different roles from clinical diagnosis to public health surveillance, and they seem to have significant limitations like false negatives, false positives, uneven quality. What do you think we need to do in scaling up to address those limitations? So as we're getting more and more tests, how do we address those limitations in quality and variation?
Well, the first thing we need to do is to have the FDA very carefully monitor what is being allowed to be out there. At first, with the antibody test, they allowed emergency use authorization for just anything. And now they see that they should revise that. They revised that. They realized that the Wild West, untested, just unleashing of these tests wasn't necessarily good because they hadn't been even required to show the most basic efficacy. And so if you have tests running around that don't work and you don't know that, you not only do you have bad information, you don't even know it's bad information. This is an example of what I call information making you dumber, because at least when you started, you knew that you knew nothing. But then if you have information that's misleading you or that could be misleading you, you now have negative information. You now think you know something that isn't true. And so we absolutely must not allow our testing strategy to make us systemically dumber than we were when we started. So we must demand a very fast process for getting these things to market. I agree with the idea of emergency use authorization that brings down the red tape that usually has to be in place. I think that's great. So lower the standards, but don't necessarily throw them out completely. I'll give you an example. They're allowing, and they announced proudly that cotton swabs, Q-tips, would be acceptable in the absence of actual swabs that were built for that. And that's a stunning admission of failure on our part to have enough testing, that they're saying Q-tips are okay. But more importantly, when they announced this strategy, they didn't even provide a modicum of data to suggest how good that was. So it could be that the cotton swab is 98% as good as the expensive little plastic doohickey. I don't know that. Or it could be half as good. So bad data is worse than no data. And so what I would say is we're learning more about this, but we have to expand with quality. Otherwise, you're actually you're going in circles and making it worse.
Right. So to the point of scaling up the testing, there was a recent estimate that came out, I think this week, from the Harvard Global Health Institute. They say 900,000 tests a day by May 15th, which is right around the corner. And they also said at this point, we're doing about 260,000 tests a day. And I think that the context here was this is what we would need to properly trace and track outbreaks and safely reopen. How do we scale up and make up that difference? And this is a question for anybody who wants to jump in.
I've spoken a lot. I want to let someone else.
Well, I would say that the only way to do it, I think, is to make it a national priority, not a local priority. It has to be something federal guidance on, that would have support from Centers for Disease Control, from HHS. It's not going to happen just by wishing it's going to happen. And there has to be better allocation of resources. There have to be mandates for what certain areas have to do. And until we do that, I don't think we're going to get to where we have to be.
Right.
Yeah, it's possible. It needs to happen. I mean, it's unacceptable that other countries have figured this out and we can't. We're looking here, as we think about reopening, we want to have testing of between 4 and 5% of our population every month. To get that, we're going to need about 200,000 tests from the federal government, which have been committed. But again, it's, we still need to receive it. But listen, if we're saying that this is a national crisis, if we're saying that we're at war, then bring it. Let's bring all the resources to bear. It's what are we waiting for?
Yeah, so a question about that. You said 2,000 tests. So does that include everything that you will need to conduct the test? Because Dr. Parsonnet mentioned earlier, there's issues with the supply for the reagents. There's issues with the supply for the swabs. And so what does that mean when you say we'll have 2,000 tests delivered? Does that mean everything included? You have all the materials you need, or is it just the tests? What does that look like?
Yeah, it's a great question. 200,000 is the number that we need over the month of May. And the goalposts have been moved a little bit. Initially, we were committed full testing kits with swab, transport media, and then enough reagent to match the testing devices we have in the state. That's kind of morphed to becoming just swabs. And so now we're scrambling to make transport media and to package it and so sort of thing. I think that's kind of, you talk to hospitals and other health departments that are trying to do this. It's just a daily hustle to try and figure out where your swabs are coming from, where your transport media is coming from, how's it going to match to what device. It's a real hustle. And if I could look ahead 2 weeks or something and know what was going to be delivered or come in, both from the public and the private pathways, I could plan. But there's no reliable way to do that right now.
I'd also add to this, I have very limited experience with being the buyer, but I was speaking to someone who is a major international supplier, and they vet through all the proper channels. And what this individual told me was, because it's such a cluster and everyone's trying to figure out what to do, he actually has, at first the hard part was finding supplies. He couldn't find the test and the PPE. Then he worked that all out. And then he says that now the problem is on the buyer side. He can't get the buyers to actually buy it at the unit level that he needs to even just to break even. And I think that's because there's 100,000 offers coming into your office, and you're trying to sort out which ones are real, which ones aren't real. And I know that there's probably a dozen that are great, and then there's 1,000 that are terrible. And so even when people have the opportunity, they're like, I don't got a buyer. And that just reflects the fact that there's no organization, as you say.
Yeah, there's you'd asked Congressman Kim the question about why he thinks the feds have been a little bit gun shy to kind of step in a little bit. It's obvious that things are becoming increasingly political by the day, and there's this sense, I see a sense on the federal level of you break it, you buy it. You know, the idea, which is a false notion, by the way, that if they just leave it to the governors and to the states and localities, they'll be absolved of any political ramifications. I don't think that's true, and it's not helping, but I get the sense that that atmosphere is playing out right now.
So we've got just 5 minutes left. So at this point, I think we should go ahead and do some closing messages from our panelists here. And I would say, so what's the key message or lessons learned from your experience in your parts of the country, both in dealing with testing, what you think still needs to happen, dealing with PPE and other medical equipment? What advice would you give for colleagues in other states, other areas experiencing the same challenges, and how you've dealt with them? What would your main message be, and what you think they should keep in mind, and what you think we should still make happen, and we can move forward?
Well, I'll go ahead. I'll tell you, I think the lessons that we've learned in Louisiana, we've been reaffirmed of the value of emergency preparedness in general. In some senses, I think we were in a good position because of all the hurricane preparedness that we do year in and year out. We have good visibility on hospitals, good data collection systems, and those are serving us well because we have really good eyes, and we can move quickly on that. And those are smart investments. They've never seemed more smarter now. On a national level, I think, listen, there are times when it makes sense to have states compete against each other, and there are times when it doesn't. And something like this, nobody wins when states are all competing and trying to reinvent the wheel. There's really a role for the federal government to be a convener and a leader, and there's real ramifications when that doesn't happen.
So I just want to reiterate what Dr. Kanter mentioned, that when you're at war, which we are, with a virus which is infinitely smarter than we are in many respects, leadership matters. And nobody would say that going to war, it doesn't really matter who's in charge. It matters what your leadership does. And we see that playing out in areas around the country, that some places have had outstanding local leadership and they've done better. And other places have had less strong leadership for various reasons, and maybe they're just competing interests. But we've not had the leadership nationally that we need to conquer this and to really move this forward and to conquer this outbreak. I think the other thing is infrastructure matters, and we have spent years ignoring our public health infrastructure. And not just ignoring it, but not bringing it up into the modern world, using the technologies that are available, and using technologies that a lot of other countries throughout the world, even countries that are much less wealthy than the United States, have been able to use to their advantage. So I think we have to really look and see how we can bring ourselves up to the 21st century standards of what surveillance should be and what public health should be. And we need to have strong leadership in public health and in dealing with epidemics.
Right. So we'll give Dr. Faust the last word here before we wrap up in the next minute.
I would say that this is a lesson we've learned a million times, but let's try to learn it again. And that we have to listen to ideas from all sides and to have a very short memory. If this White House had said on January 10th, we need to have a complete travel ban for everyone in the whole world, how many lives would have been saved? But no one would have believed that coming out of the White House because of past policies. So a really good idea would have been dismissed out of hand because we would have questioned the motive of it. And similarly, today, a really, really good idea can come from another part of the political spectrum, and I'm worried that it'll be dismissed out of hand by people in power for the same reason, because they sense a credibility gap. And we can't afford to have that. And I remember John McCain talking about that after the 2004 election, was before he was a nominee. The next year, I remember him talking about what needed to happen for the country to heal. And we thought it was vitriolic then. And he said, the number one thing we need to do is to assume that our adversaries on the other side of the aisle have good intentions and to listen to their ideas. And I think that is what we have to learn here, because if we don't, many lives will be lost. So the second thing that I would just add and ask of everybody is that as we successfully flatten the curve, that we do not become a little bit immune and numb to the daily smaller but long-term death tolls, the death by 1,000 cuts. I'm a little concerned about that. And so we have to keep our eye on the prize. And the way to do that is to continue to talk about it and to continue to collaborate in the ways that Dr. Parsonnet and Dr. Kanter have said. Thank you so much.
Right. Yeah, so we'll end there. And thank you so much, Dr. Parsonnet, Dr. Faust, and Dr. Kanter for joining us. I think this has been a great discussion. For folks who want to hear more from us and our partners on what you can do and stay informed, check out USPIRG's website, get us PPE and Doctors for America as well. Stay informed, and thank you again so much, everybody, for joining, and to our panelists.
Thank you.
Have a good rest of the day.